Yes, we can see it. We can see your
Okay.
presentation.
Okay, thank you so much. Afternoon, everyone. It's an honor and a privilege to join you today in this important workshop where I will discuss with you the protection of health, safety, and well-being of primary healthcare workers. So in this presentation, we'll speak about the common occupational hazards in primary healthcare, and we'll touch a bit on the control measures. We'll talk about the impact of COVID-19 for health and safety at work in healthcare. And also I'll touch about the WHO resources for protection of health, safety, and well-being of health workers. So before we proceed, I'd like to highlight a couple of definitions. First is the definition of occupational health, which is the area of work in public health, which aims to promote and maintain highest degree of physical, mental, and social well-being of workers in all occupations. The science and practice of occupational health, it is multidisciplinary, which involves occupational medicine, occupational nursing, ergonomics, work psychology, occupational hygiene, safety, and many others. So another definition is the definition of health workers, which refers to all people who are engaged in work actions whose primary intent is to improve health. And this includes people who are directly involved in providing care, such as doctors, nurses, midwives, public health professionals, laboratory workers, community health workers, even traditional healers. But the definition also is wider, involving health management and support workers, such as cleaners, drivers, hospital administrators, social workers, and other occupational groups that are in the health-related activities. So as we can see, health workers involves not only people who are involved in direct care, but those who also support those who are involved in the front line providing care. So now, looking closely at the health sector, it has been shown to be one of the most hazardous sectors. And this has been so even before the COVID-19 pandemic. And this can be demonstrated by the data that you can see on the slide, where in Africa, 41% of health workers are exposed to hepatitis B, hepatitis C, and HIV. However, only less than 18% of the health workers have been vaccinated against hepatitis B. In the case of TB, about 54% of health workers in low, middle, and middle income countries have latent TB. And during the 2014 to 2016 Ebola outbreak in West Africa, the risk of infection for health workers was over 30 times higher than the general population. In the case of COVID-19, in the first 17 months of the pandemic, more than 2,000 health workers died from the disease, and we think this could be an underestimate. Chronic low back pain is a major issue, with up to 80% of nurses in Africa in the clinical settings having chronic low back pain, and this being a risk factor for health workers leaving the workforce. Health workers, particularly medical professionals, are at high risk of suicide in all parts of the world. And during the COVID-19 pandemic, frontline health workers suffered from depression, anxiety, and insomnia. Violence and harassment is also a big issue, with health workers reporting cases of violence in the range of 9 to 100%. The range is wide because it depends on where this data is coming from, but the highest has been reported in South Africa and in Egypt. So some of the elements of primary health care that put primary health care at risk of exposure to occupational hazards and the associated health risks is high patient load, where primary health care units are the first point of contact for most of the members of the public, and therefore they may have greater throughput of patients, and hence this may in turn lead to having higher potential for exposure to occupational hazards. And one might even might think that because someone is in primary health care, maybe the risk is lower compared to workers in larger hospitals. But it's been shown that health workers providing primary health care are exposed to more or less similar hazards, which a wide range of hazards, similar to the hospital-based healthcare workers. The work dynamics in the primary health care also determine the hazard potential for the health workers. Primary healthcare work alone or in small teams, and this means that they have responsibilities which range from providing direct clinical care and day-to-day running of their practices. And this has the implication for the extent of the hazards that they may be exposed to, but also the implication is also on the controls of the hazards that and the associated risks. The general practitioners also act as employers, and this adds the complexity on the work dynamics, because then they're associated with the responsibilities to ensure the health and safety of other workers and the patients, in addition to the responsibility of protecting their own health and safety. And primary health care in most places work in relative isolation from other sectors and may be separated from supportive colleagues, and that also may add to the potential for them being at risk. So looking at the hazards, there's a wide range of hazards that primary healthcare workers are exposed to, and this varies by settings, the occupations and tasks. And in general, these hazards can be categorized as infections, including TB, hepatitis B and C, HIV, respiratory infections such as coronaviruses and influenza, ergonomic hazards, which are related to manual handling of patients or heavy loads, hazardous chemicals. In health sector, there's lots of chemicals, cleaning agents, stimulants, mercury, toxic drugs, pesticides, etc. And like issues of occupational injury, slips, trips and falls, electric shock, fires and explosions, which have been reported, road traffic injuries, where there are cases of ambulance crashes or motorbike and bicycle injuries for health workers who go into communities. Like I said, violence and discrimination is a huge issue with a range of physical, sexual, verbal, and psychological abuse and harassment being reported among health workers. There are risks in the ambient environment, which includes noise, thermal discomfort, heat or cold stress, occupational stress, burnout and fatigue, and which are related to time pressures, lack of control over work tasks, working long hours, shift work, etc. And last but not least, the environmental health hazards, where some health facilities have been shown to have unsafe and insufficient water for drinking and washing, having inadequate sanitation and hygiene, and not having proper ways to treat hazardous healthcare waste. So how does one deal with these hazards? So the one way to deal with this risk is to ensure that the good health risk assessment is conducted, which is referred to a method of evaluating the risks to safety and health arising from the hazards at work. So a health risk assessment generally would involve 5 steps, with the first being identifying the hazards in the workplace using checklists, screening instrument, and other tools which are widely available. And this will be used to obtain an overall impression of the potential risks and hazard for each of the tasks that are performed in the health sector. And then after identifying the hazards, comes the process of evaluating the risk, which will depend on the probability and severity of the potential of the health problems that are caused by the specific hazard. And this process will determine if any control measures must be taken for the specific hazard. After evaluating and prioritizing the risk, then one decides on the preventive actions, which follow a hierarchy of controls that we'll discuss in the next slide. If possible, it is recommended to avoid the risk rather than reducing it. Then after deciding on the preventive actions, then the actions will be taken then for necessary improvement. And when taking action, it's important to specify who is involved in controlling the hazard, when and when that hazard will be controlled. And after taking the action, then all the actions will be documented, and then there's the process of monitoring and reviewing of the controls to ensure that those controls are effective, but also those controls do not create additional risks to the workers. Looking at the controls, as I've said, they follow a hierarchy of controls with the most effective control measures at the top and the least effective at the bottom. Here, elimination is the most preferred method of control, where you physically remove the hazard. For example, when you speak about needle stick injuries, discontinuing using of non-safe engineered devices, or when you speak about mercury exposure in dental procedures, the act of discontinuing using the mercury in dental procedures, that will be considered elimination, and this is the most preferred method of control. The below it is substitution, where you replace the hazard. For example, to deal with hazardous cleaning agent, one might choose to replace the hazardous cleaning agent with a safer alternative. The third method is engineering control, where you isolate the worker from the hazard. For example, to prevent needle stick again by using self-sheathing needles, or using needles with engineered injury protection or needleless systems. And below engineering controls is the administrative controls, which changes the way people work by providing training, medical surveillance, vaccination to health workers at no cost, following the vaccination program of the country, fit testing, adjusting the work schedules to avoid fatigue and burnout. So all these are administrative controls to ensure that the way people work is changed so that to protect their health and safety. And at the bottom is provision of personal protective equipment. And this is the least preferred because it depends on individual behaviors. So one would want to put elimination, substitution, engineering, and administrative controls first before providing the personal protective equipment. So, so for the specific control measures for the hazard that we've mentioned, I encourage you to visit the WHO website, where you'll find an e-tool on occupational hazards in the health sector. And these there's a list of hazards and the respective control measures that are based on WHO and ILO recommendations and good practices. And this tool will be updated regularly to ensure that it contains the most up-to-date and evidence-based recommendations for protection of health workers. So I highly encourage you to visit the WHO website and interact with this tool, and provide your feedback when you're able to, in order to improve the tool. So looking at health workers during the COVID-19 pandemic, so it's been evident that the COVID-19 pandemic unmasked what has been going on for the longest time in the health sector, which is the health sector being one of the most hazardous sectors. And so, and what happened in the COVID-19 pandemic and why were health workers at high risk during the pandemic is first and foremost due to poor health workforce management. And this is referred to as the social determinant or the cause of causes. And this has led to hazardous working conditions for the health workers. And this is the proximal risk, which has led to occupational acquired COVID-19 and other disorders. WHO has issued an interim guidance on occupational health and safety for health workers, which is available in different languages on the WHO website, with several recommendations on how health workers can be protected during the COVID-19 pandemic. So I highly encourage you to download this resource and read on how we can protect health and safety of health workers in our region. So even before the COVID-19 pandemic, there was high political commitment to act on health and safety in the health sector, In 2019, the United Nations General Assembly high-level meeting on universal health coverage was held, and the heads of state and government committed to several actions which are to be implemented in the countries. Of note is the action number 38 and 64, which speaks about scaling up efforts to promote healthier workplaces and improve access to health services, noting that more than 2 million people die every year from preventable occupational diseases. And action number 64, which is specific to health workers, urging countries to take necessary steps at the country level to protect health workers from all forms of violence, attacks, harassment, and discriminatory practices, and to promote their decent and safe working environment and conditions at all times. In the case of WHO and ILO, WHO, in several times, the Director Generals of WHO and ILO have urged countries to develop strong national programs to protect health and safety of health workers and other medical professionals. However, only 1/3 of countries globally have some national policy instrument for protection of health and safety of health workers. And in Africa, this is only about 10%, with countries such as Ghana, Togo, Uganda, Kenya, Tanzania, and South Africa having programs for health workers existing in implementation. Other countries such as Gambia, Sierra Leone, Botswana, and Mozambique are in draft process for developing this policy instrument, while other countries do not have such policies. WHO is urging countries to develop these programs because they've been shown to be effective in protecting health workers. So why is protecting health and safety of health workers important? First is for regulatory compliance. Many countries do have occupational health and safety regulations and acts, which requires the protection of health and safety of all workers. So if a health sector protects the health and safety of the health workers, then they'll be complying to the regulatory requirements of the country. But also protection of health and safety of health workers has been shown to improve productivity of health workers and also ensures quality of care and also patient safety. So it's been evident that patient safety and health worker safety are linked. For example, if in the health sector or in the hospital, there's chipped floor, the patient would be injured, they'll fall, but also the health workers will fall. If there's noise in the hospital, health workers will be affected, but also patients will be affected. So protecting health workers directly also protects the patients. And there's this example of when you board a plane, there's always that instruction that says, when there's an emergency, you should put on a mask on yourself before you try and help somebody else. So the same should apply in the health sector, where the health workers should be protected first so that they can be able to protect others. The protection of health and safety of health workers increases the resilience of health services in the face of outbreak and public health emergencies, but also it stimulates retention of health workers by improving their working conditions and showing that they're being cared for. So in February this year, WHO and ILO issued a global guide for the development and implementation of occupational health and safety programs for health workers. And in this guide, WHO and ILO urges countries to develop and implement occupational health programs at national, sub-national, and facility levels. Also to introduce new and update existing regulations and standards for protection of health and safety of health workers, ensuring that occupational health and safety of health workers is part and parcel of the management of healthcare at all levels, that health and safety is part of the core business of health sector, and ensuring that health workers have access to competent occupational services and advocating for synergies between occupational health and safety and other programs in the health sectors, and such as IPC, patient safety, health workforce management, etc., but also collaboration with other stakeholders, employers, and workers. So this guide is also available on the WHO website, and I highly encourage you to go through it and see how you can develop and implement these programs in your countries. WHO also issued an online training course on occupational health and safety for health workers in the context of COVID-19. This is a self-paced course that is freely available on the Open WHO website, and we'll also highly encourage you to take up this course and learn how health workers can be protected in the context of COVID-19. So last but not least, I'd like to highlight the upcoming project between the African Union, WHO, and ILO on the protection of health and safety of health workers in Africa. And this is an evolving project with the aim of building political commitment for placing health worker safety in the center of healthcare management, raising awareness about occupational health for health workers, and coming up with local solutions that will work in Africa, and building capacities for development and implementation of occupational health and safety programs for health workers in different countries, and also creating mechanism for exchange of experiences and good practices between countries. As we've seen, some countries are quite advanced in this process, and some are still developing their policies, and some have not even started. So the aim of this project is to ensure that there's a community of practice where countries would share experiences and learn from each other. And lastly, to establish a committee and organize different workshops to be able to learn from each other and learn how these programs can be developed and implemented, and overall how health workers can be protected better. And we look forward to interacting with different countries based on the regional economic communities, and see how best we can protect our health and safety, the health and safety of our health workers. So to conclude, I would like to highlight this few key messages. First is to say that the health sector is one of the most hazardous sectors we've seen, with the range of hazards that health workers are exposed to. And it is important to protect the health and safety of health workers because it improves the quality of care, it ensures regulatory compliance, it increases the resilience of health services in the face of outbreaks and public health emergencies, but also stimulates the retention of health workers, making sure that they are staying in the health sector instead of venturing into other activities. But also healthier, safer, and fairer, and more inclusive world of work is crucial in the recovery from COVID-19. Thank you for your attention.
Relating to the incidence of diseases in the healthcare sector and noting a wide variety of occupational health hazards that are actually exposed on a regular basis within the healthcare sector. And so, do we have any questions or comments for the speaker? You can raise your hand or post it in the group chat before we break into our smaller group sessions. Sorry about that. Connection's just slightly unstable.
I'm sorry, Jamie, we can't hear you. You're breaking up. We could just adjust your audio a bit, or Patience or Kim, go ahead. Patients, I don't know, maybe there's a problem with your audio. You can just type your question in the chat. Dorothy, I can see someone asking, how do we get the different government buy-in? I think it might be in relation to the project that you're doing with Africa in terms of occupational health and safety.
Thank you, Mercy. So, with the project, but also with the protection of health and safety of health workers, the first thing that is recommended, especially even with the guide that we have published, is to ensure that there is political commitment from the government. And there are several strategies that have been highlighted for ensuring that there's political commitment. But first is to explain to the government why these programs are important. And as we've seen with the COVID-19 pandemic, when the health sector shuts down, everything else shuts down, because that's how how powerful the health sector is. So showing the government how important it is to protect the health workers would ensure their buy-in, and also building that political commitment. And also having champions for the health and safety of health workers, that also helps. So like I said, we have the guides, which has different strategies on how to ensure there's political commitment, how to get the government to buy in with this, and why these programs are important, and showing the added value of the programs. In this call, I also have the Dr. Ivan Ivanov from the Global Occupation and Workplace Health Program that I was hoping you'd introduce himself, and maybe add on the questions that I have answered. Dr. Ivan, are you there?
Thank you, Dorothy. Yes, I'm here. I was listening to the discussion, and with regards to governments, it's the most important is that governments should understand that healthcare should be safe, and no minister would argue that healthcare in his or her country should not be safe. And safe healthcare means healthcare is safe also for patients and for workers. In particular, primary healthcare providers, they face challenges with having decent working conditions. First of all, because they are so scattered around, they may not belong to one organization that would have the capacities to ensure their protection, that would develop programs. So they are mostly left by them to themselves, and they may not even have access to occupational health services to look into the working conditions, to do the medical examinations, to provide vaccinations. So this is an enormous challenge in the organization of primary healthcare, and the fragmentation of healthcare systems at the local level is also resulting in poor working conditions for health workers. Thank you. That's my 5 cents.
Thank you so much, Dr. Ivan, first of all, for joining us today, and for those very insightful comments, and for really highlighting the difficulties that primary healthcare workers in particularly face. And for me, my question would be around the mental health component, because in your presentation, Dorothy, you did mention that depression and a lot of isolation, anxiety, amongst other things, were some of the things that were noted in healthcare workers during COVID. And I'm imagining also before COVID, it was there, only that there was no opportunity or trigger to look for it. So in this new program that you're working on with Africa how much does mental health of healthcare workers feature there?
Thank you, Mercy, for your question. Like I said, the project with the African Union is an evolving project, and it is to ensure that there are comprehensive occupational health programs for health workers. And with comprehensive programs, it's all hazards, like I mentioned, from infections to mental health to everything. So like I said, it's an evolving project with different objectives. So, and it will all, again, it depends on the requests of the different countries and what needs to be focused on. But what we would want is a comprehensive program that does not fragment care. Say we're going only to deal, say, with HIV, or we're going only to deal with say needle stick injury, but more comprehensive that deals with everything in totality, because mental health does not come on its own. It also comes with other hazards that we've seen before. So what we're advocating is to have a more comprehensive program, and with the evolving project, I'm sure all the hazards will be discussed. But Dr. Ivan is going to add more on this.
Yeah, thank you very much. On the 28th of April, sorry, on the 28th of September this year, WHO will release global guidelines, evidence-based guidelines on mental health at work. And one part of these guidelines also concerns the mental health of health workers and emergency responders. And basically, what we recommend in these guidelines is to regularly carry out a risk assessment of the organizational risk factors for mental health. These are the psychosocial risk factors, to provide training to health workers about how they can protect themselves from mental health exposures to psychosocial risk factors, how to recognize the early signs of mental problems that they may have related to their work, but also train the managers about how they can support workers in protecting their own mental health. So stay tuned with us on the 28th of September on the WHO website. The guidelines will be released together with a WHO ILO policy brief on mental health at work. Thank you.
Thank you so much, Ivan, for that. We will be looking out for that 28th September. And I think those guidelines will be actually a landmark, or not a landmark. It'll actually be a very great event, and also a milestone in terms of occupational health and safety for health workers, because we have a tendency of looking after others and forgetting to look after ourselves until that starts affecting our work, our families, and also our patients. So I think that would be very great, and we will be looking out for it. Anyone else with any questions or comments before we move to our breakout sessions for discussion today? I can see some comments in the chat. Patient says, with the situation in today's services, how will we make government to save the health workers from danger? I think that's a similar one to the one that Dorothy answered earlier. Health insurance for healthcare workers, any plan? That is from Alice and Richard Paul. And then health screening programs for various conditions, e.g. breast cancer. Could it be policy to have it mandatory for health workers in facilities? That's an interesting one. Dorothy or Ivan, either of you can take that.
Yes, I see Ivan raised a hand, but with health insurance, again, these are country specific, but we advocate for health workers to have, first of all, the protection For example, if somebody gets an occupational disease, for them to be able to have the financial protection and compensation for the lost time or the cost of taking care of themselves, or if they've lost any income from working, then they should be compensated. But also health insurance, like we've been to several places where health workers do not even have coverage for disease, to even non-occupational diseases. So we advocate for that, and also for social protection of the health workers. So, but again, this is the country specific, depending on the national regulations and the plans that countries have. But WHO strongly advocates for health worker protection, which includes compensation for occupational health and safety, occupational health hazards, and diseases and injuries. And for screening programs, like I said, for in the hazard controls, there has to be an occupational health service, which has all the services for the health workers. So for the occupational service, it depends on the resources that are available, depending on the country and how much money is there. Primarily, one would want to cover the occupational health issues, ensure that there's screening, there's pre-employment screening, periodic screening of the workers, and exit medical examination of the workers to ensure that they don't have diseases. However, an occupational health program or an occupational service can be elaborated to include other screening programs, breast cancer, family planning, and as many things as it is possible, depending on the resources. But on the occupational health point of view, at least at the minimum, there are some services that must be there, and they've all been highlighted. If you'll be able to go to the guide, you'll find out. But medical surveillance, fit testing, like the risk assessments, doing risk assessments, all those must be included in the occupational health program, and then include others like providing primary health care to the workers, or vaccination is an essential part, but saying including family health and other things that will depend on how much resources are there. Dr. Ivan, do you have anything to add on that?
Well, the only I can add that there cannot be a talk for universal health coverage if the health workers don't have coverage themselves. So it will be pure hypocrisy on any government to advocate universal health coverage and to say that they are on track with this sustainable development goal. Dorothy reminded me in Sierra Leone when we were in the health workers were saying they don't have health insurance at all, and they don't have also insurance for occupational diseases and accidents. And if someone falls in the hospital or in the healthcare facilities, the colleagues, they have to collect money in order to pay for the treatment. And this is really extremely sad. Poor healthcare facilities, poor working conditions, making people sick, and on top of that, they have to pay for that. That is it. Thank you.
Thank you so much for those comments, Ivan and Dorothy. And I especially like your comment, Ivan, that it would be hypocrisy to say you're achieving universal health coverage if the healthcare workers are not considered or taken care of. And I think that is a very important point to take home. So right now we are going to go into our group discussions, as we always do with our workshops. So I would like to ask from the participants about 4 people to volunteer to be the facilitators for the groups. Just raise your hand and then I will rename you as a facilitator. The job of the facilitator is just to facilitate discussion. I will post the discussion questions on the chat. You will go into your groups. The facilitator will help with the introduction of the members of the group, and then go through the 3 questions one by one. And then either the facilitator or another rapporteur can take down notes, and then we'll come back for a plenary discussion. And the point of these discussions is always to see what are the people on the ground actually experiencing, what are the challenges. And after looking at those challenges, can we come up with our own solutions? As you've heard, we are coming up with a framework, with a policy framework as AfroPHC, and that framework actually is derived from the kind of discussions that we have in these policy workshops. So I'm not seeing any raised hands. Anyone who would like to act as a facilitator? Or maybe we can select rapporteurs once we get to our groups. So I have posted the questions on the chat. If you can see the questions on the chat and you have them, please give me a thumbs up or a handshake or a high five, just to see that everyone has gotten the group questions for discussion. Sorry, there. Thank you, Joseph. Okay, so received. Thank you very much. So I am going to send you into your groups. You can choose a rapporteur to take notes, and the rapporteur will afterwards come and give the points that you have discussed in plenary. And then we'll have a short discussion, and then we will close the workshop. So let's go to our groups.
and lack of personal accomplishment, issues, some of the causes that were mentioned, people, the workers in primary health care are understaffed. There's a lot to do for only one person. There's unconducive working environment, prolonged exposure to stress, loss of patients, as in the case of COVID, people doing monotonous work and doing the same work for a long time. Maybe there's a need for job rotation, loss of job control. So those are the, some of the issues that were mentioned as causing burnout. And for the policies and strategies for protection of primary healthcare workers, what was mentioned was to have a policy for compensation of health workers in case of occupational diseases and injuries. Also to have policies that have taken into consideration patient safety and health worker safety, as in the case of Kenya. That was mentioned that they now in the process of developing this policy that looks at how health worker safety and patient safety can be integrated, using accreditation and licensing in the implementation. As I've said, from fellows from Kenya who've mentioned quite strongly that this has been helpful because there are elements of health worker protection that have been included in the accreditation of health workers. So now it's mandatory for a health facility to be accredited. They have to ensure that the health worker, the work environment of a health worker is health and safe. There's also a point that the policies in themselves are not enough. There should be implementation, because there might be nice policies like, say, immunization, people need to be immunized, but then there may not be enough vaccines for everyone. So the action plan must be there for implementation of the policies. So also the spoke about policies for education, training of having specialists, say, for mental health at work, so that to assist the health workers, but also in general to have training of health workers on how to protect themselves, and also to train the focal points for occupational health to ensure that the measures for protection of health workers are implemented. And also to have policies for occupational health and safety to ensure that the not only pre-employment medical examination, but also there are periodic and exit medical examination when health workers leaves the service. Also mentioned that there may be a need to learn from the private sector, because it seems like the private sector is doing very well, but what is it with the public sector that we are not matching up to the efforts done by the private sector? And just one more point, that training of having policies for training health workers is well and good, but there must be mechanism to create posts for employing these specialists who are being trained in occupational health, so that they can come into the health system and assist in the protection of health workers. Thank you.
Thank you so much for that feedback, Dr. Ngajilov, and for room one for sharing those insights with one another. It's quite interesting to see how our room also had similar but also different things to add. So great, we have our repertoire. I was in group 2, so let me just, great, you're sharing your screen and you're able to unmute. Perfect. Would you like to share what we discussed in room 2?
Yeah, I think much has been said already by the recent presenter. On question 1, it's community involvement, yes, at facility level as one of the strengths. Relief workers to relieve the shortage, and these are supposed to come maybe from the referral hospital, from district hospitals. And also meetings can also guide others, can be fruitful to the PHC facility, considering that they discuss and work together. If it's a patient, they can refer, or if it's somebody they're referring to the community, they will understand if it's HIV, if it's nutrition. So if they meet as a neurologist, occupational health therapist, and so on, possibly this will work better for our facilities. On the negative part, we are talking about access to water. Clients have to fetch water. This is one of the challenges. It's not only one country, but most countries also, water is really a challenge. And of staff burnout, much is high workload. In most health facilities or occupational health centers, most of the facilities, they have 1 to 2 nurses, others have 3, meaning that one is on night duty, one is on day, and one is off duty. So it's indeed a challenge. There are very few facilities with 6 to 8 nurses, including a department. Community sensitivity, yes, cultural beliefs can also hinder much of what is happening in the community, and also the health workers can also have challenges in managing some of the clients. Stock of commodities has already been said, it's supplies and drugs. If they are not there, then patients are there. They will talk much about the health workers, but they will not understand if they don't have the adequate resources. PPE is one of the challenges. If conducted delivery without a PPE, without gloves and so on. Sometimes you use surgically clean gloves instead of sterile gloves. This is one of the challenges also. No power that affects communication. This is quite bad in most countries, and provision of care has been affected. And in other countries where maybe people need to be put on oxygen, they usually die, considering that there are no cylinders available in those facilities. Electric internet, yeah, quite true. In most African countries, we have that challenge of electric phone and internet connection. And also poor communication and referral systems. In order to refer a client to the community, sometimes it's quite difficult because you can give them the communications, but they will not know to give, as there's already a challenge with multidisciplinary team meetings in some of the countries. Multidisciplinary team is fragmented. It also backs up the poor communication and referral systems, because if you don't sit together and discuss and come up with areas, know each other, we will not know whom to refer to. Limited space and infrastructure, most facilities are quite small. So there's quite limited space for some of the care which needs maybe counseling and so on. The infrastructures are very limited. Delayed reporting systems and interventions, most of the times it takes long if people are reporting issues. If they report and they don't get feedback, and sometimes there is delay in telling them what to do. For example, in the issue of COVID, yes, people would understand what is on the ground, but much of the information which was being given to the PHC areas was quite limited, and people would just do things which were not right. On the burnout, we are talking about difficulty retrieving files. It's very limited considering that there is no electronic files. So you need to search one by one, so it takes long. Limited resources, we have already talked about that. It's part of the burnout issue as well, considering that they might not have enough supplies and so on. They might be committed to work, they might be there to work, but they don't have enough resources to use. Lack of supervision support, this is one of the governance issues which is not being tackled in most African countries. Managers do not visit them, do not support them. Most of the time they will just shift them. You are moving to another facility. You know, you have to go to this facility. No, you have to do this. But what is there on the ground? Have you ever been there to see what they are doing? Do they have challenges? So if there is supportive supervision, possibly you might learn from them. High staff attrition and also community interference. We have already talked about that one. And the low incentives. Most community workers receive very little incentives in African countries. So on the policies, we are talking of community engagement and participation to support primary care facilities. Continuous provision development also, they need to be on the ground. What is new in the market? What should they use? If they are managing malaria, if they're managing cases, what are the new drugs currently being used? What is the new information which they're supposed to use? Most of the people who are working in these facilities, they're outdated, they are old. They have been there because that's their village, possibly their home area. So they might not have enough information. So they need this information as well. And compared to the medical checkups, this is also very good. But considering that there's only one nurse or one clinician in that facility, it also it's also quite difficult because when we talk of medical checkups, they need to travel and leave one nurse at that facility. Possibly they need to do spot checks with the relevant authorities. And also monthly general staff meeting is also good for them to share what their gaps are, what their needs are. Continuous engagement for operational staff as part of motivation. This is also part of where they're supposed to understand how to go about some of the issues being managed in the other referral hospitals. Government protocol approach, most projects usually they come from the government, but there's no assessment done to identify gaps and needs at a community, and there's no involvement. You'll just be told there's a project coming, which is not quite very good. So it's important possibly the government to do bottom-up approach. The community should say what they want and involve them when they're doing the planning of the projects. Community to be involved in the management of the facilities. It had mixed views. Some said yeah, some said no, but we just have to define the roles. What are they supposed to do? So at least the clear roles will guide how the community should be engaged in, instead of maybe using village health committees. And health facilities as well have to come up with clear overtime guidelines. In Malawi, we call it locum. Locum is the west part, and others would work 24 hours or maybe 48 hours non-stop. They knock off at 7, give a report, they start again. It's quite very bad and it's hectic, and it's also not good for their health. So we need to come up with clear guidelines how people should work for this overtime. I think that's all from our team. Thank you very much.
Thank you so much for reporting back for breakout room 2. I think one of the things that we definitely spoke about that breakout room 1 also mentioned was the fact that we can have nice policies, but implementing them is not always easy. And one of our participants also mentioned that with regards to limiting overtime, some individuals might want to go above and beyond that, particularly for remuneration purposes. So that was just a bit of a debate we were having. I don't know if there's anyone else from breakout room 2 or 1 that has anything to add to what has already been said. And then if I could also ask anyone who is a rapporteur for any of the other groups to please just raise your hand so we can make you co-host. Alice and Richard, would you like to say something? You can unmute.
I would like just to add on what the other participants have said. Like for the positives, there are some countries which are very well trained personnel that they are not even employed. And I would like to take an example of Kenya. You have a lot of qualified nurses, qualified doctors, clinic officers, and these people have not even been deployed because of the lack of the policies and strategies in place. I will not repeat what the others have said. So this is an area that, okay, that is a positive that they are trained, and the negative is that they are not employed. And one of the negative experiences that we have variable quality of care at different levels. The primary health care is level 1, and you'll find that the primary health care in a town, a city like Nairobi, varies from a primary health care in the village. For example, in Kakamega. So there is that variation of quality care. And then lack of resources. Also, the resources are not equitably distributed between these two health facility areas, city and the rural area. And then there is lack of support. That is the salaries, which has been remuneration, which has been mentioned, the voice of the nurses, and the empowerment of the nurses. And of course, manpower, it has been mentioned before. I'll not go into the hours, but I'd like to mention that, as the Malawi nurse said, I've worked in most of the around Africa, and you find that the nurse at the primary health care, she's the same one in the emergency. She will be there doing the outpatient. She'll be doing the vaccines. She's the one in the delivery room. She's the nurse also on call at night. So that long working hours, and they are not well trained. So that's an area, a negative one. and there are shortage of specialties at the primary health care. So, and mentorship, there isn't much mentorship at that level. PPEs have been mentioned, energy has been mentioned. Then I'll move on quickly to burnout, and the burnout factors that we came up with was monotony of the work without having any other variation. Then emotional and mental stress because of the workload. The other thing was lack of personnel resources at that level, and it has been mentioned by the other groups. Control, the nurse at that level has no control. She's not recognized, so she's emotionally upset. There's dysfunction at that level of a facility, including that where areas where you have the community workers, you might find them working in the clinics and doing work that should be done by the qualified staff. So work-life imbalance in that the nurse is working 24 hours. And then lack of retraining, then out-of-date practices. And also unclear job description, because if you're employed as a nurse, then you should be a nurse and you should not be doing the clerical work, because they do multitasking. For policies and strategies, I will not repeat what the others have said, but I'd like to say that they should be early diagnosis through routine screening of the health facility of health workers, which is not done. And then, of course, the political commitment of recognizing the health workers, their safety, remunerations, and the resources. And then also their mental health and their job descriptions, the health insurance, compensation has already been mentioned, and the improvement of water and sanitation. That is the basic facilities at the primary healthcare. Not all primary healthcare have the basic facilities. And then the other thing that referral systems, you find that if you are at the primary healthcare, you are stuck with a patient because you do not have an ambulance, you don't have, that patient needs to be moved on, but you do not have the facility to move this patient on. So anyway, and then emergency preparedness. This is one thing that needs to come in and be at all levels of the primary healthcare, so that they are ready for an emergency. COVID came in, none of the primary healthcare facilities were ready. Even when you have outbreaks of malaria, they don't have the emergency preparedness. The other thing that we talked about was community living standards. So that if you have a community that eats well and has good shelter, then obviously the primary health problems will be less. Thank you. Our group, if there's anybody else who would like to add something, you're most welcome.
Thank you so much, Alice. Can I just confirm, were you room 3?
Yes.
Oh, perfect. Thank you so much for those contributions from room 3. Definitely interesting, and I agree, it needs to be made almost compulsory for there to be routine healthcare assessments of the healthcare staffs, just to check for burnout, but also for common communicable diseases that we're at risk of obtaining. So thank you for that. And anyone else from group 3 or group 1 or 2 or any other group that would like to add to what Alice has said? Otherwise, we can move to our feedback from group 4. Okay, should we move to group 4? If the rapporteur could just unmute.
Hello, I'm unmuted. My name is Yvonne.
Hi, Yvonne. Thank you. Go ahead.
Most of the points have actually been talked about when it comes to the safety of the healthcare. And the few things that came up that have not come up from the others, you find that in the health and safety, you find that the positive thing is that some of the companies actually are able to bring in a psychologist for psychotherapy sessions because of the anxiety that was there, because of the COVID cases, which was good because of the healthcare workers. But on a negative aspect, you find that during the pandemic, we didn't have funding. So that service was there, but it was dependent on the availability of the funding. And especially if you are working with an NGO, they don't have a lot of contingency funds. So you find that it was a strain to the safety of the health workers in all aspects, including getting the PPEs. And also in terms of now, how some workers will have to go home because they're unwell, and others has to have long hours, which has also been mentioned by others, which also includes the lengthening of shifts. So when it comes to things to do with the burnout, of course, we actually defined burnout. Then we talked about why others get burnout. So you find that there are several factors that we discussed that can actually bring that in play. One of the first thing you find that we didn't have the knowledge, so there's too much work. You don't know, the communication was actually poor, so you find that people were not sure what to do. One day you're told wear a mask, the next day you're told not to wear a mask. So you find that back and forth was stressful to the health workers because they didn't know actually what to do, and actually it stressed them up. That was it, changes in the guidelines, and of course they were frustrated. And if you find something else like the lack of promotion, which I think has also been mentioned in a different way. So you find that also people are also being delayed in working payments. For example, in the counties in Kenya, we find that there's a lot of delayed payments. So workers work, but they don't get their remuneration on time. And the policies that are there, we also discovered that in our Kenya facilities that we have something that is going on that's called Join Work, which is a tool for measuring burnout in the two facilities that we've mentioned. The other thing you find that in the policies, we need to strengthen the occupational health department if there is one. If there is none, we should be able to incorporate them in the healthcare systems. The other thing we need to do is we need to destigmatize mental health and bring out the awareness. By doing so, you find we can have safe spaces, or even have a linked psychotherapy so that you can be able to know what's happening and have the conversations going. This also can also occur when we have the multidisciplinary teams meetings, such that people can be able to understand what's going on in our facility. The other one, of course, we talked about the mandatory assessments for healthcare workers, which is important. And also the last one we need to have is we need to motivate our healthcare workers in terms of making sure we have a policy that says you should not have delayed payments. If you have due to a job promotion, it should be followed through. We should not have a back and forth, because it demotivates our healthcare workers and they get stressed up and not able even to work. I think that's the most that I could get from my group. Thank you very much.
Thank you, Yvonne, for sharing the ideas from your group. I think we can definitely see some recurring themes with regards to involving multidisciplinary teams. I think these can be really beneficial. We always talk about treating patients in a biopsychosocial manner, but we also need to look at ourselves and how we can manage ourselves biopsychosocially as healthcare workers before we can provide health to others. So thank you, Yvonne. And then I think we have just one more group. If we have a representative from breakout room 5, if they could please either raise their hand or unmute so that you can share the discussions from group 5. While we're waiting for the representative from group 5, we have an addition from Dennis in the chat, who has just said that he would like to point out that risk assessments and industrial hygiene assessments are not being done for medical facilities. Ergonomic assessments, noise exposure, biological hazards should all be evaluated for by qualified technical persons. Thank you for that addition, Dennis. I don't know if we have a representative from group 5.
Hello, it's not group 5, but it's group 4.
Oh, okay, yes, go for it.
Yes, as many points have been already mentioned by previous presenters, we are going to cover those who were stated in our group. Mainly, one of the points that others didn't mention that was mentioned in our group was regarding the negative points that were seen as healthcare workers. One was mentioned that there are some physical aggressions for healthcare workers that have been noticed in some healthcare facilities. That was the main point that wasn't mentioned by others. So regarding the burnout, main points like work overload, a lot of patients, working hours that are very long hours, lack of human resources in some facilities have already been mentioned, and some of the times healthcare workers do not have time to rest. And the main 3 points that I can highlight in our discussion group we had was regarding maldistribution of human resources as the main factor for burnout, as in some of our countries, we do see that rural hospitals or rural healthcare facilities do have lack of healthcare personnel, and that has like an impact on the work overload for those who are available at those healthcare facilities. And the other thing was a lack of competency distribution, as mainly we do have general practitioner nurses only in primary healthcare facilities, and mainly they do take care of all the patients that arrive at those facilities, and we should have like a competency distribution or do like a task shifting in order to compensate that. The other thing was a lack of motivation, as one of our group mentioned that sometimes we do have healthcare workers that do spend like more than 10 years without any motivation, and that may be one of the factors that can lead to burnout. And regarding the solutions or the policies or strategies, we thought in our group, the first one was regarding the awareness for population that healthcare workers do have rights, and so that the population may be aware of the rights of healthcare workers, so that they do not get aggressed physically or by speech. And the other thing was to try and raise the number of healthcare workers so that the work overload and the lack of human resources be tackled, and so that they may have time to rest in order to prepare for the upcoming shifts. The other point or strategy was mainly the implementation of the WHO tool, which helps to allocate well human resources or healthcare workers regarding to the patient care ratio, also to the staff, work overload, the population density, and mostly that that tool also takes in consideration the distance between the healthcare facilities and where the population lives. So we think the tool is always already available, so the implementation of that tool will be very useful for our communities and our governments. And also the other thing mentioned was regarding the PPE, has already been mentioned by others. And also the last one was screening, to have screening for healthcare workers for that may help for prevention and early identification for healthcare workers in case they have like infections or other accounted infections while doing their work. So mainly those are the main points that we had in our group. Thank you.
Thank you, Mugisha, for those additions. I like that your group raised the issue of the aggression towards the healthcare staff. I think that is definitely a fact worth noting and something that our group did not actually discuss. So thank you for those additions. And I think we definitely see a common theme being presented by some of the groups about healthcare workers feeling demotivated and overworked. So thank you for that. Charles, you've raised your hand. You can unmute and share.
Well, thank you for the opportunity. Sorry, at the time I had technical issue from my side, so I could not continue with my group before. But I want to chip in, having heard what Innocent presented, I want to chip in also the strategies and policies we can be advised to take up the WHO to the workload indication of working needs in assessment to mitigate burnout in our establishment. And I will also want to note that in some of our sites, in some of our workplaces, a number of NGOs and IPs are very supportive in provision of materials, in provision of PPEs, and some other materials to help reduce the rates of negative experiences that are affecting the healthcare workers. And also note that in some of our sites, even the healthcare workers have personally been involved in upgrading or providing certain things, using their resources, their money to make available whatever tools that they may need in their sites to facilitate provision of care to those that are in need. Low motivation is a very highly a point that must not be overlooked in one of the causes of a burnout. I think at this stage, I will want to thank you for the opportunity and say it was very nice, a good experience discussing with participants on my group. Thank you.
Thank you so much for that contribution, Charles. Hannah, I can see you've raised your hand, so you can unmute and feel free to share with the group.
Yes, please. Thank you so much. Very rich discussions. It might be a controversial issue, but as we move towards population-centered, people-centeredness, and universal health coverage, I would like us to also consider community-based monitoring or a partnership with the community to monitor what goes on in the primary facilities. It's not negative. They might also bring positive contributions to the primary health facility and defend the health workers at the primary health facility as their presence. So again, emphasizing the role of the community as a positive partner in running a primary health facility. So community-based monitoring, I would strongly recommend as well.
Thank you so much, Hannah. That's actually something that our group had mentioned as well as something that could be quite beneficial. Mercy?
Thank you, Jamie. So as I was listening to the discussion, one thing that came to my mind was, could we also be the ones contributing sometimes to our own deterioration in health in terms of burnout or in terms of any other thing that affects us either mentally or physically? Because what I have seen in most African healthcare system is the issue of working in silos. Everyone works by themselves. We never work as a team. And when you work as a team, you're just not a group of people who show up to work in the morning. You work together. Everyone owns the patient. When something goes wrong, it's everyone's issue. It's not one person's issue, because I find that could be a huge contributor to burnout and poor health. Because if everything falls on you, if there's a problem, you solve it on your own, whether you're a nurse, you're a doctor, you're an intern, you solve it by yourself, then that can increase pressure and also increase burnout. Also in terms of, do you care about the other person you're working with in a team? Let's say we are working in shifts. My shift ends after 6 hours, after 8 hours. Do you show up on time for the next person to be relieved and go home? And when you show up, Do you do your part? So that just got me thinking to things that we ourselves can do, especially as primary healthcare workers, knowing that we are few and we have very little support. How much support do we give each other? And are we working as a team? And if we are working as a team, how well are we working as a team? Such that the nurse is not somewhere by themselves doing something else, the doctor by themselves, the community health care workers by themselves. Because I find that if we come together and we work as a team, then that is another way, another strategy of really improving health, because your stress levels will go down. You share the burden of work. And considering we spend most of our lives at work, if you reduce stress at work, you solve a lot of your health problems, I believe. So thank you. Just something to think about.
Thank you, Mercy, for that addition. I don't know, Alice, I think you raised your hand in response to something Mercy might have mentioned. Alice, you are muted. Just if you can unmute yourself.
Hello. Yeah, this was in relation to community-based monitoring. And I just wanted to add that in most of the countries I've worked in quite a number of African countries, you have what we call community health committees. And these community health committees, they just need to be trained more so that we to meet our expectations, because they are there and they are the ones that take care of the clinic. You find out that most of them the boundaries of the clinic, some of them take care of the cleanliness of the clinic, and also the welfare of the health facilities and the health workers. So if there are any countries that don't have these community health committees, I agree with Hannah that it should be introduced, because it is a very vital thing in operation of PHCs.
Thank you. Also, just adding to what Mercy had said about the multidisciplinary teams and working together, I think that was something that we had also mentioned in our breakout room, where we said multidisciplinary teams can really be a positive and can help alleviate burnout. And I know that one of the breakout rooms also spoke about having clearly defined roles within the workplace, so that you're not taking on other people's responsibilities and overworking and overburdening oneself with things that are not necessarily within their job description. So if we can work as a team, I agree with the points Mercy has raised. I think that also is taking it upon ourselves to also reduce what we can with regards to contributing to our burnout. I don't know if there's any other, I don't know if we've had a representative from room 5 yet, who's able to provide feedback from their discussion.
If I'm not wrong, I think we've had 5 rooms.
We've had 5. Okay.
Yes, yeah, because we had Dorothy from room 1, then we had Alice from room 2.
Room 2.
And then who else am I leaving out?
We had
Yvonne, we had Innocent.
And we had our project Echo.
Yes, so we've already had the 5 rooms present.
Perfect. I don't know if there's anything else that anyone would like to add from what we have discussed, or anything that they think is worth highlighting from the discussions that we've had. Okay, I don't know if there's any additions. Great, well, thank you to everyone. Before I hand over, I think it will be to Mercy. I just want to say thank you for this opportunity to moderate today's workshop, and thank you to our speaker for the very insightful discussion around this topic. And I really appreciate all the contributions made by all of the groups. And thank you to those who volunteered to represent their groups, and for all those who participated in this discussion and ensuring that it was a very fruitful and enriching discussion this afternoon.
Thank you so much, Jamie, for moderating the session. Thank you, everybody, for joining us today. You're the ones who make these policy workshops. You're the ones who come and give your time and also give your opinions, which are very important, because at AfroPHC, it's important for us to know the people working on the ground. What are your challenges and how can we help to solve them? So in lieu of that, we are developing a policy framework on building the primary healthcare team for universal healthcare coverage in Africa. You can go to the AfroPHC website and click on the policy button, and you'll find a copy of the document there. Please go through it because AfroPHC received a PHCPI grant to develop this policy framework and also to develop AfroPHC regional chapters. We will be having regional chapter consultations on the documents and also on just building more of connection with the various countries through regional AfroPHC chapters. So they're every Friday, and you can check on the website and see when your region is coming up. This Friday, 19th, we are having the East Africa region chapter consultations. So you can just check on the website and it will show you when your region is up. So please join us, read the policy document, come and contribute on the policy document, and also on how AfroPHC can be taken forward in your regions, in your countries, including how to engage various policy stakeholders. And with that, I would like to call upon Francois. Francois, are you here? Are you still here? Francois, our deputy, the deputy president for AfroPHC, to close the workshop for us. Over to you, Francois.
Hello?
Yes, we can hear you.
Yeah, good afternoon, and I want to thank everyone that took time to attend the meeting today. And in fact, the discussions that was shared here were quite rich enough. I do hope that we have really gained a lot on the healthcare workforce, and we are moving forward into us helping ourselves. Sorry, please. So as we are moving forward to helping ourselves and helping our colleagues and help the environment as primary healthcare activists, so that we'll have a better care for the community. Thank you, Dorothy, for the rich contribution, and everyone. Thank you, Jamie. Thank you, Mercy, and everyone that contributed to the rich conversation today. I do wish you all a happy stay. Bye-bye.